The next session is panel discussion on hepatitis B or C. Our moderator, Dr. Ashish Goel, and our esteemed panel, Dr. Debashish Datta, Dr. Akash Roy, Dr. Vishal Chaurasia, Dr. Chirag Desai, Dr. Manoj Agarwal. And a small reminder from my side that we will have to wind up this session within sharp 15 minutes.
Thank you to the organizing team for giving us all this opportunity. I welcome all the panelists here. We will wind up in 15 minutes. We will stop short of whatever we are achieving. And I see Dr. Akash Roy has joined us instead of Dr. Saptarshi Vishnu. So, yes, let's start with the problem statement. Why are we discussing it when we already have high barrier nukes and HCV, DAs and HB to treat hepatitis B and C, but still there is an enough burden of hepatitis B in any of the transplant centers, and we will know about that. There is of course, initially it was considered as a contraindication, but all these therapies have made it all possible that we take hepatitis B and C as routine indications for transplant. The second point that we need to know is that there is always indication for increasing the donor pool, and still there are a lot of HBV infected people in the world, and how do we increase the donor pool in that aspect? So why prevent hepatitis B and C recurrence? Immediately after hepatitis B or C graft, we can have, which immediately affect the survival of grafts, leading to fibrosing cholestatic hepatitis in an occasional case. On medium and long term, it can lead to hepatitis B or C cirrhosis, hepatocellular carcinoma, and a lot of the drugs are effective in this aspect. So coming to the topic itself, we will divide it into 4 scenarios where recipient is hepatitis B, donor is hepatitis B, or recipient or donor is hepatitis C positive. So when we say recipient is hepatitis B, what we have to know is what is hepatitis B recurrence in the recipient after transplant. So reappearance of HBsAg or HBV DNA, which was undetectable previously, should be considered as hepatitis B recurrence. Immediately, it can have mild self-limited hepatitis. It can go on to chronic hepatitis. Occasional patient will have fulminant hepatitis or fibrosing cholestatic hepatitis. There are risk factors for that, and the major risk factor is what level of HBV DNA do we go in with transplant. So all our transplant centers will sort of look for very low HBV DNA in recipients at the time of transplant. So low pre-transplant DNA or undetectable DNA is what we aim for, and that is considered as low risk. A patient who has high viremia at transplant, who has acute on chronic liver failure, or poor adherence to treatment, HIV co-infection, and history of drug resistance are all considered as high risk factor for hepatitis B recurrence. So let me ask first question to Dr. Debashish Datta. To prevent hepatitis B recurrence, do we need to modify immunosuppression in the recipients?
The important question is with the new nucleotide and nucleosides, the importance of immunoglobulins has gone down quite a lot. So I think we can probably safely give it, but it's important to monitor them closely.
No, I will agree with Dr. Datta. I think we don't modify immunosuppression as well, and we use the usual immunosuppression in our patients. Dr. Manoj Agarwal, do you check for coexisting HDV, and does it influence outcome in these patients, HBsAg positive recipient?
I think for a HBsAg positive recipient, yes, you should check for coexistent HDV. The importance is because if you have HDV positivity, which can be there, I think the incidence is coming down over the years, but still about 5 to 10% of people may be HDV co-infected. So the decision here is going to be how long are you going to give immunoglobulin? And most of the time in this group of patients at least, the immunoglobulin may have to be given for indefinitely. Otherwise, I think with the drugs which are available now, you keep the HBS, hepatitis B itself at bay, then HDV doesn't seem to influence the outcome ultimately.
I will agree with Dr. Manoj Agrawal here that hepatitis D relies on hepatitis B presence, and so if we keep HBsAg at bay, HDV doesn't usually come into picture. We at our center do not check HDV regularly, but we found that HDV is very, very rare in these group of patients, so not regularly for our transplant recipients. So what can we do for hepatitis B recurrent prevention? The initial era was HBIG. Before this HBIG in 1990s, there was almost an 80% recurrence rate with almost 50% graft survival only. So with HBIG, the recurrence rate dropped by 20%, and initial studies had very high level of HBIG to maintain a target anti-HBs level of 500 almost the entire post-transplant period. So almost 10,000 units of IV has to be given. The problem was the cost of therapy. For us, around 2,000 international units costs around 1 lakh. So if we have to follow this protocol, it will be at almost 3 to 4 times the cost of transplant itself. And compliance is another issue with injections. Availability of these HBIG across the world is a problem. Limited efficacy and side effects is a problem. But more and more the world has moved over to nukes, and with the lamivudine and then subsequently with high barrier nukes like entecavir and tenofovir, this scenario has changed, and HBIG plus nukes with a limited HBIG dosage leads to almost very low recurrence rate of almost less than 2%. So now the clock has wound to the other side, where they are saying only high barrier nukes, no more HBIG, at least in the low risk population, as we have discussed before. The initial studies with lamivudine alone were still, because of high resistance, there was 50% recurrence, but with entecavir and tenofovir, the recurrence rate is quite low, especially if you are choosing the patients. What we have to realize that nukes cannot prevent reinfection and establishment of CCC DNA, and therefore there is always a theoretical risk of HCCs on long-term follow-up in these patients. Multiple studies with HBIG sparing options are available now across the world, more so from the eastern subcontinent, where they have discontinued or not used HBIG at all, and they show a recurrence of HBV, and the duration of study can be as high as almost 10 years of 7 to 8 years of study data is available, with almost 80 to 90% recurrence-free hepatitis B recurrence-free survival. So maybe Akash can take this question. When are you comfortable in using nukes only strategy?
So as per the last 𝐒𝐿𝐼 consensus, the only area we'll be using only nukes is those who are at very low risk, defined as was defined with the undetectable DNA or less than 4 logs, and you don't have any of the high risk factors. You don't have HCC, you don't have HDV, you don't have even an ACLF. We don't know what happens to ACLF group when you get transplanted. So in that specific subgroup, which are very low risk, we might consider this nuke only strategy.
Okay. Thank you, Akash. And Dr. Debashish, again, if you use HBIG, what is the dose used and for how long?
I agree with Akash. We will use only HBIG in very high-risk patients and start with 10,000 units initially during the surgery, and then do it every week for 7 days. But there has been studies with 5,000 also, which has been found to be quite useful. And in serious risk patients, you can carry it on every monthly or even every 2 monthly for almost a year.
Is there a target anti-HBs that you are looking at?
I think more than 100 is okay, but ideally more than 500.
So what we do in our center is a very low dose HBIG, almost 2,000 units intra-op and hepatic phase, and then give 2,000 units every alternate day for 1 week, and then we shift over to IM use, which is 200 units IM can be done on an outpatient basis. We target at around 100 anti-HBs for initial 3 months. Any of the Dr. Chirag Desai or Dr. Vishal Chaurasiya can take this. There is a role of hepatitis B vaccination, though it's not very clear. But do you use hepatitis B vaccination as a strategy?
No, no. No, yeah, please.
A regular hepatitis B vaccination in a HBsAg positive patient as a recipient is not advocated. The only situation when you would think about vaccination is where the donor is anti-HBC positive, recipient is negative, and you did not have enough time to vaccinate the recipient pre-transplant.
So what we do is we will maintain anti-HBs level for the first 3 to 6 months. And if the person remains HBsAg negative, the recipient, for 1 to 2 years, we will try and vaccinate the recipient to bring up the anti-HBs level by vaccination. But that is again, it's not across the centers. So this is what Dr. Akash was alluding to, the recent ELITA recommendations of dividing the HBsAg recipient into low risk and high risk. And in a low risk population, either you can use NUCs alone, or as our center, we use NUCs plus HBIG and discontinue HBIG at 4 weeks. At high risk group, we can use and try and discontinue HBIG at 1 year. And this is the dosage which they have sort of recommended. HBIG of 5,000 units per day IV for 7 days, and then every 2 months for 1 year. Only in a special population of HDV or a poorly adherent population where they may be used for HBIG lifelong. So hepatitis B recurrence, is there any choice of NUCs that you have, Dr. Manoj?
I think entecavir and tenofovir both are equally good in terms of efficacy and resistance barrier. But TAF, I think TAF definitely, from the renal point of view, its harm on the kidney is less. I would prefer TAF actually, and also depends on, what the patient has previously been on. Sometimes we just continue that.
So what we do is we prefer entecavir immediately post-op because of renal problems with the tenofovir. And but there is recent data on the use of tenofovir alafenamide, and we show that it has been shown that it leads to some improved renal function as compared to tenofovir TDF. So we move on to donor Hep B and see if we can cover some part of it. Only anti-HBC positive donor, which constitutes 10 to 50% of the donor pool. Most of the centers will accept this donor. Almost always we know that there is a chance of recurrence, and there is always presence of cccDNA in the hepatocytes in these patients. But still most of our centers will accept these donors for both hepatitis B and hepatitis B negative recipients as well. So Dr. Manoj, what NUCs do you use for anti-HBC positive donor?
Same. I think we would
Only
prefer either
anti-HBC
entecavir or
positive.
TAF.
So what
Between
we
NUCs.
use is only lamivudine in these patients, only anti-HBC positive. Maybe the chances of recurrence are very low. We will come to it later. And do you ever discontinue NUCs here?
Why lamivudine?
The chances of anti-HBC positive donor, I'll come to that. I'll come if the time permits. And Dr. Akash, you will give NUCs in all these patients with anti-HBC. Is there any subgroup where you won't give?
So technically everybody gets it, but if you want, there is a very specific subgroup which would be both anti-HBS as well as anti-HBC positive. You might not consider it there.
So natural immunity patients may not require NUCs here. HBsAg positive donor, this is again a recent sort of fashion where we still try to increase the more donor pool, more so in the eastern part of the world. And there is a strict selection criteria for HBsAg positive. Most of us may be reluctant to use it, but if we have no liver fibrosis in the donor and the recipient has no HDV, it can be used preferably in HBV positive patients or a patient who may not survive the waiting list. So we know HCC risk is higher if the donor is perinatally infected. Now most of our donors in India will be perinatally infected. That is something that we need to take care. But there is recent data to suggest that mortality and graft loss, if we are using HBV positive grafts, is comparable to HBV negative grafts, at least in over a period of 7 to 8 years. So let me just finish these questions. I think Dr. Chirag Desai can take this. When do you consent for marginal donor? Is it at the time of transplant or for DDLT setting? Is it at the time of listing itself?
Patient is always explained at the time of listing, and there are patients who are not willing for any marginal donors. So the comment is made in front of their list that these patients may not be agreeing. But obviously, if there is a marginal donor just before the transplant, they are informed about the condition and the risk associated with it, and it is part of the video consent.
Dr. Chaurasia, will you be happy to take HbSAg positive for LDLT?
Actually, if you look at it, there's a difference between the medically whether we can take it or not, or it's an ethical question. So if you ask on a personal front, medically, yes, I might believe that if it can be done in LDLT, and if the viremia is negligible, they can substitute as a good donor. But since there is no consensus as of now, and there are a lot of ethical concerns, I would refrain from taking any HbSAg positive with any viremia, especially for LDLT right now.
If there is a HbSAg positive donor, maybe Dr. Chaurasia himself can take it. When do you start HCC surveillance, if at all you do take it?
Ideally, for all, not only for this subgroup, for all patients with any kind of viral hepatitis B or C, with none also, we usually start every 6 monthly, we screen the patients with ultrasound and AFP post-transplant. So it's not a different from
So I would suggest that I think HCC surveillance in any
important.
HbSAg positive donor or recipient is required.
Yes.
HBG administration, again I would pass that question, but it's because you're putting a donor which is HbSAg positive. Initial studies said HBG administration, but nowadays it's not there. We'll just, okay. So let me just say hepatitis C positive donor. So more and more people are willing to take hepatitis C positive donor with newer DAs available now. So maybe Dr. Manoj can just tell me about hepatitis C virus testing in donor. Is there any difference, or?
I think you should, the antibody test can miss many of the people, and it only tells us whether the person has been exposed. I think a NAT testing should be the norm.
So NAT testing.
And even the NAT sometimes may miss a high-risk donor, like somebody who's, say, a drug addiction, who's had recent exposure. The NAT test may miss it, but overall, I think NAT is the one which we would use.
So I think NAT testing is the way for donor screening. And Dr. Desai can take this question, whether are you happy to screen a donor for HCV with fibroscan to say no fibrosis, or do you need biopsy in that patient?
No, I would always prefer biopsy. And the fibroscan is not available in all donor hospitals.
So
I'm sorry for the interruption, but we have to sum it up in next 1 minute.
Okay, thank you. So again, just one important point that I wanted to tell, that hepatitis C, if we are sort of transplanting, we tend to start DAs, and if there is a donor hepatitis C positive, we tend to start DAs very early in the course. So maybe within the first week of transplant. And there is again not much of change in immunosuppression, whereas we have to watch for drug-to-drug interaction. So let me just summarize here. We need to expand the donor pool, and we need to do it safely. So we are trying to take in hepatitis B positive, HCV positive donor, and all these new drugs are sort of helping us in expanding that pool. But eternal vigilance, as Sir said, that we have to do HCC screening in most of these patients, and similar vigilance has to be maintained for long-term management. Thank you.
Thank you so much. Thank you, everyone. And I would like to request all our panelists and moderator to please join in for a group picture.